I guess I've lived at that intersection of housing and health policy for quite a few years, so I really appreciate the opportunity to be a part of this discussion today. And I think maybe building on both the first panel and then Brian's comments right now, I think we do have a lot of evidence that housing assistance for some people in particular may be the best medicine, that it helps people stabilize their chronic health conditions, it keeps people out of the hospital, it just makes an enormous amount of sense. It improves health outcomes and just gets us a better result for the public spending and the private spending as well. The challenge is to get the policy worlds of Medicaid directors and housing advocates and housing officials lined up, because if Brian says as a Medicaid director he hasn't seen that evidence, that's really telling about the separation and the separate languages that I think our worlds are using. But what we do see is that among people who are living, particularly people who are living in deep poverty, there's very high rates of chronic health conditions, of untreated mental illness and substance abuse problems, and high rates of housing instability and a need for affordable housing. So if we can put those solutions together, we can do a better job with the resources that we have. I wanted to pick up a little bit, I'll try to pick up a little bit on what we were just talking about in terms of managed care, but also address some of the other health-related proposals in the paper. I think in managed care there is a real difference between the big managed care plans that have primarily insured workers or moms and kids in Medicaid, and the kind of mission-driven or specialty managed care plans that are designing some really innovative programs to coordinate care and to reinvest the savings that can come from keeping people out of hospitals and emergency rooms and nursing homes. But the challenge, as Brian said, is that we really need to make sure that the rates that are paid to those managed care plans are not based on an average consumer, but that they're risk adjusted. They're adjusted to pay the right amount of money. We know that about 5% of Medicaid beneficiaries are responsible for about 50% of the dollars. And so if we're really going to get some savings, we need to create incentives for plans to design and implement, and for providers to implement better care models for that 5%. But if you pay them the average rate, they're just not going to be able to make those programs and those efforts sustainable. So we need to have the right payment mechanisms, the right performance incentives. Again, for serving a very high-risk population, you may see really big improvements in quality, and they're not going to reach the kind of quality measures that are used for a more average population. So that means measuring changes in quality indicators on a relative scale, as well as looking at absolute benchmarks for quality and performance. And we're really moving in the healthcare system towards a lot of quality metrics around things like hospital readmissions, as well as access to appropriate care. I also really wanted to touch on, I could talk about any of these recommendations because I think they're all really important, but I want to follow up on particularly recommendation number 9 about the availability of services to address substance abuse problems. Right now, we frankly have, in most states, Medicaid benefits and other public funding in the publicly funded substance abuse treatment system that have created, in most cases, a very separate system of treatment programs that can be very effective for a very small number of people, but frankly, for most people, they're either inaccessible or they function as a revolving door. And they're not linked to health care, they're not linked to housing, they're not linked to the child welfare system, they're not linked to the places that people with ongoing alcohol and drug problems tend to take their problems. And so when we talk about increasing the availability of services that address substance abuse, those services need to be integrated into primary care. They need to be integrated into the services and supports that help vulnerable people with serious health problems get and keep their housing. And that means paying for program models that are very different from the ones that are currently financed through Medicaid and under other funding sources right now. It means focusing on helping to create the motivation to change for people whose lives are really a challenge on a day-to-day basis, and helping people live successfully in the community. Some of the Housing First programs that have been created for chronic inebriates, for people with serious alcohol problems, have really kind of shaken up our understanding of what kinds of models work to house people who continue to drink but drink less, but have those programs have demonstrated savings of thousands of dollars per person in costs for avoidable emergency room visits, hospitals, detox, and that kind of revolving door care. And we need to make those kinds of models more widely available in more communities. I think the other point that I would make about the recommendations, both number 6 in terms of Medicaid in general and also the recommendation for federally qualified health centers, is that some of the models of care that we're seeing that seem very, very promising or that have demonstrated the kind of evidence that's described in the Center for Healthcare Strategies paper. It's also described in a paper that I'll make a plug for a paper that APT prepared that is published by the Assistant Secretary for Planning and Evaluation, ASPE, at HHS, that summarizes the evidence base for linking health services and Medicaid services to housing for chronically homeless people. We've got a lot of evidence that doing this produces very significant savings in healthcare expenditures. But the kinds of services that really work require a different set of care providers. They require not only doctors and nurses and specialists and the kinds of things we think of as healthcare, but they require us to really rethink what healthcare is. So they require staff who do care coordination, and there's a lot of evidence that the kind of telephonic care management that's offered by some managed care plans isn't effective with this population, that it needs to be face-to-face. It needs to be attention and relationship building and trust building, not only helping to navigate and ensure that healthcare providers are talking to one another, but that people are motivated to feel hopeful that if they take medicine as directed, or if they make changes that we all know are really hard, whether that change is to stop smoking or drink less, or to unclutter your apartment so there's not you're not going to get evicted, or to change the way you take care of your home so that your kid's not having lots of asthma attacks and going to the emergency room. Those are not easy changes to make, and they're not changes that people make as a result of a conversation in the doctor's office. They're changes that people make because someone has spent time with them face-to-face, offering the encouragement and the motivation building and the coaching that it takes to do problem solving on a day-to-day basis. And that's what I think the best and most effective of services in a housing setting do. And that's what housing and supportive housing and service providers linked to housing tell us is the hardest thing to finance with the payment mechanisms available right now. So I think while there's certainly some interesting conversations about which pocket should pay for housing and whether savings in Medicaid expenditures should be reinvested in housing, I think there's this big area of paying for the services that help people get and keep housing, and there's a lot of room to make change there.